Hi, this is Elliot Fishman, and welcome to our latest edition of You Make the Call. You may remember it's a very simple game. I'll show you two images, one slide, and I need you to give me the best diagnosis possible. I'm not going to give you a set of choices, but we'll simply discuss the case. So without any further ado, let's get started. In this case, what's the best diagnosis? Well, what are we looking at? We're looking at compression of the right kidney by a soft tissue mass. It's not arising from the kidney. It looks like it's compressing the kidney. It's in the perirenal and pararenal space. It looks like it may involve the right psoas muscle. The contralateral left kidney looks good. The little bit of the liver and spleen we see look okay. So what is going on here? It's a great question. Well, think about it. What occurs in that area? Well, one thing is you can get metastasis, though that would be really large, and the most common thing to go to that region would be melanoma. You could have high density if the patient had a renal biopsy or had trauma, but you might expect to see active bleeding, and this really is solid. It doesn't have the look of blood, and there's nothing anywhere else. We talk about tumors that arise in the space, perhaps a tumor arising off the capsule of the kidney. That's a thought, but it would look different. The kidney here is compressed and displaced, and the psoas muscles involved. So what else occurs in this region? Okay, think about it for a second. Now, when we talk about kidney masses, we talk about renal cell, we talk about mets, we talk about benign lesions like angiomyolipomas, we also talk about lymphoma. Remember how we speak about lymphoma can be a solid mass, can be multiple masses, can be diffuse infiltration, and isn't there a fourth way? Yeah, perirenal involvement. So what's your diagnosis? Your diagnosis is renal lymphoma. This is a great example of renal lymphoma with involvement of the peri and pararenal space. Excellent example of the infiltration, displacement of the kidney, and interestingly, it's unilateral. Again, renal lymphoma typically is bilateral, and solid or multiple masses are more common, but this is not an uncommon appearance. Again, I mentioned metastasis like melanoma would be a thought, lung cancer would be a consideration, but I've never seen it with such large masses. So to me, oh yes, other things in the perirenal space, extramedullary hematopoiesis, but that typically infiltrates the entire kidney, and usually it's bilateral, and the spleen would be enlarged. Also things like Ernheim-Chester disease, infiltration of the perirenal space, but again, that's 360 degrees, and that's not the case here. Just a terrific case. When you look at these two images, what do you see? Well, it doesn't seem to be very difficult. It looks like there's a fluid collection, which is high density, involving the spleen, and it's compressing the spleen, and it really looks like a splenic bleed. Now, let me give you the history, and let you think about this some more. This patient has severe left upper quadrant pain, and the patient is within a day of getting colonoscopy. The patient was not in an MVA, the patient did not fall down, the patient was not hit. Well, when you think about it, and you look at these images, it still looks like a splenic laceration with a large bleed, but how's that possible? Now, sometimes patients have underlying splenic lesions which bleed. We've talked about this in the past in patients who've had pancreatitis and CTisus, which dissect into the spleen, that they can get spontaneous bleeds. We talk about patients with mononucleosis. When the spleen's really large, you can get spontaneous bleeding, but here the spleen is normal in size. So how do we connect it to colonoscopy? Well, there's a number of articles, and I just finished a talk that'll be on CTisus on complications from colonoscopy. We talk about bleeding post-biopsy. We talk about perforation, although rare. We also mention splenic injury. In patients, particularly those who've had inflammation where there's adhesions between the spleen and the region of the splenic flexure, if the endoscopist is a little bit forceful, or even it's just the colon is tortuous, it is possible to get a splenic laceration. So splenic laceration, splenic injury, so capsular hematomas, you name it, are all possible. And so in this case, when I ask you the diagnosis, it's going to be splenic injury post-colonoscopy. An unusual complication, but if a patient comes to you post-colonoscopy with pain, you got to be thinking of colon perforation, bleeding, particularly if the patient had a biopsy or a polyp removed or something like that, or laser, or the patient just simply had injury to the spleen. I've not seen a case, to my knowledge, of liver injury. Of course, the spleen is much more delicate, and also it's more difficult at times to get around the flexure, and once you reach the hepatic flexure, you don't quite have the force, and if you can't get through, you typically will stop at that point. This patient presented with back pain, and when you look at the axial images alone, you see a paraspinal mass. So I'm thinking about lymphoma and maybe infiltration of the spine. What else gives you paraspinal masses? Neurogenic tumors, but it's not low density. Even though this is a non-contrast scan, it's not the typical low density of neurogenic tumors. So adenopathy, maybe it was a patient with esophageal cancer. Maybe it's lymphoma. Other things, extramedullary hematopoiesis, that's a thought. When you have bone involvement and you look at the sagittal views, things become clearer, because what you see is there are multiple vertebral bodies with a gibbous-type deformity, and the vertebral bodies are destroyed. Now, you can get infiltration by lymphoma. You can get infiltration by neurogenic tumors like neurofibromatosis. But when you have the destruction of bone, it really is focusing on an inflammatory process, and the angulation makes you think about Pott's disease, which is classic basically for tuberculosis. We don't think about TB as much as we used to perhaps, but TB can present in the year 2023 as back pain. We talk about TB as a cause of hematuria. We talk about TB for hemoptysis, but also back pain, Pott's disease. So paraspinal mass, I'll think of lymphoma. I'll think about neurogenic tumors, but I'll also think about infection with IV drug abuse, infection in E. coli, but typically you have a discitis. Here there's discitis, but there's destruction of multiple vertebral bodies. And when you think of that, your differential diagnosis is going to make you exclude TB. And this was a great case of TB of the spine with Pott's disease. Just a wonderful example. This patient had abdominal pain, and you can see that we did a very, very nice example of non-contrast kidneys, but there are multiple lesions present. Most of the lesions are fat. If you put cursors on them, they measure between -50 and -100. There are some solid masses present, but you know, when you have angiomyolipomas of the kidneys, of course, that's what I'm thinking about with fat, not all the lesions are 100% fat. Remember, one of the more common solitary lesions that are resected and are worrisome for tumors is an angiomyolipoma with minimal fat. So in this case, particularly well shown in the coronals, we see multiple tumors in the kidneys with fat consistent with multiple angiomyolipomas. Typically, an angiomyolipoma of the kidney, AML, is an incidental finding typically in 40-ish-year-old females. When you have multiple lesions, it's usually a syndrome. And you're thinking, what's the syndrome? It's tuberous sclerosis. So a beautiful example of bilateral renal angiomyolipomas with tuberous sclerosis. You might look carefully at the liver. Patients often get lipomas in the liver. And you look at the lung for cystic changes. This is a great case in a patient with left flank pain. If you look at the abdominal image, you see that there's no flow to the left kidney. And if you look at the left renal artery, you can see that it's cut off. It's amputated. There's a thrombus sitting right here. So now you have infarcted left kidney. There are many things that can give you an infarcted kidney. A thrombus in the aorta. Endocarditis is a very common possibility. when I look at the limited exam of the patient's chest, I see multiple pulmonary emboli. Now you ask the question, pulmonary emboli and aortic thrombus, that is in the renal artery, so you have stuff on the arterial side and the venous side. What is showering, or how is it that you can have the connection? And there's been a number of articles about this, and this is classic. Think about it. Think about it hard. What gives you stuff on the pulmonary arteries? We know pulmonary emboli is a lot of reasons. Renal artery occlusion, there are a lot of reasons, but what gives you both? Well, what you need to have is a patent foramen ovale, and then you have the thrombus going through, giving you PEs and giving you clot in the renal arteries at the same time. Just a very classic appearance. So if you see that, sometimes you may not appreciate the patent foramen ovale on the chest images, but it's there, and this is a great diagnosis. In this case, we see a large mass in the left paraortic region that's vascular. When you look at the coronal view, it's beneath the level of the adrenal gland. If it was adrenal, then I would have said a pheochromocytoma, right? You could have considered a primary adrenal cortical carcinoma, but when it's very vascular and well-defined, it's typically a pheo. You might ask if this patient was hypertensive, and indeed they were. But what gives you vascular masses, but it's not the adrenal? So vascular masses in general, I tend to think about neuroendocrine tumors. We think about pancreas lesions like peanut tumors. We talk about some neuroendocrine tumors of the small bowel and mesentery, but this is in the paraortic region. The thing you need to think about, everybody together, paragangliomas. Paragangliomas are ectopic pheochromocytomas. They're outside the adrenal gland. They can occur in the bladder. They can occur in the mediastinum. They can occur in the neck, like carotid body tumors, for example. But in the paraortic region, that's what I'm thinking of. Could this be a large nodal mass from lymphoma? I guess, but it's the only mass, and lymphoma typically is not hypervascular. Castleman's disease can be vascular. I guess you would think about that, but very vascular. And then, of course, you'll think about the clinical history, and the answer, dun-da-da, is a paraganglioma. Just a really, really nice example of paraganglioma. What's your best diagnosis in this case? Well, from the axials and coronals, I'm showing you bilateral adrenal masses. They look, particularly on the left, cystic, though on the right it looks cystic as well. So what can give you bilateral adrenal masses? Adenomas, okay? But this doesn't look like adenomas. Metastasis. Metastases have a range of appearances. They're vascular with renal cell. They can be cystic with renal cell or lung cancer. They can be cystic with melanoma. And it's not uncommon for Mets to look different, even in the same patient from right to left. So that's definitely a possibility, okay? What else? What else could it be? Could it be adrenal cortical carcinoma? That's rarely bilateral. Usually it's larger. When it's bilateral, there's one huge mass and a second smaller mass. Mets is a good thought, as we mentioned. But what else? Bilateral adrenal lesions, 10% of pheos are bilateral. So you got to really consider pheochromocytomas. Pheos can be cystic or solid. We always think about them as hypervascular. Obviously, you do a clinical history, you look at the metanephrines, and this patient was indeed hypertensive. Now, when we talk about bilateral pheos, if that's what you're considering, it's usually syndromic. Neurofibromatosis 1 is one of the syndromes. We have bilateral pheochromocytomas. This patient actually had neurofibromatosis, and these were, think about it, bilateral pheochromocytomas. I love this case because it gives you a differential of bilateral adrenal masses, it gives you a differential of cystic masses, and also emphasizes the history of syndromes. You got to know what's going on with your patient. What about this case? You see a large mass, and the question is it adrenal or not? It's pushing the kidney down on the right side and has a lot of fat, or it's all fat, seems to have a capsule and has some higher density within this part of the lesion, right? So what could this be? If I want to be devil's advocate, I could say, how do I know it's not a liposarcoma? Liposarcomas are the most common retroperitoneal mass. They're often infiltrating. They can be well capsulated, so that it's possible. But I'm thinking about this lesion. It's the adrenal. It's an incidental finding. This is going to be a myelolipoma. Myelolipomas are one of the causes of spontaneous adrenal bleed. Typically over 5 centimeters, they will be resected. Patients can present with flank pain simulating renal disease, simulating liver or gallbladder disease because they bleed. And this high-density zone is an area of prior bleeding. There's no active bleeding going on at this moment, but this is prior bleeding. So just a really, really nice example of that. So think about it again, liposarcoma, myelolipoma of the adrenal, and this was a giant adrenal myelolipoma. Myelolipomas can be small, a centimeter even, can be multiple, can have minimal fat with coarse calcification, and can be large like this with blood. Just a really nice example. This patient presented with flank pain. One thought was acute cholecystitis or acute pancreatitis, and what you see in these images is a large subcapsular bleed in the liver, and you see multiple hepatic masses in both the right and left lobes. So now you say to yourself, did the patient have trauma? The answer was no, but of course the key thing is there are multiple masses and a bleed. What are the causes of bleeding in the liver? And you'll go through a differential. Hepatoma, hepatic adenoma. Those are the two biggies. FNHs theoretically, but I never see them. Hemangiomas showed a biopsy or trauma. I never see them bleed. I've seen occasional cases of metastasis. I've seen occasional cases of lymphoma. But invariably, in my mind, the presence of a bleed in the absence of trauma, and surely when there's a mass present, is hepatic adenoma, particularly when the liver is not cirrhotic, as is the case here, and hepatoma is number 2. And multiple masses in the liver, hepatic adenoma is a good thought. And this was due to a metastatic neuroendocrine tumor. I was sure, positively sure, these were multiple hepatic adenomas. I didn't think it was hepatoma, so hepatic adenomas. I mentioned Mets to you, but the number of times I've seen Mets spontaneously bleed, it's this case and maybe a couple others. So again, differential diagnosis is something you got to think about. Look at the rest of the scan. The fact is, I didn't see another mass. If I saw a mass in a different organ, then metastasis, surely if it was renal cell, for example, I would have gone that way. But this is just a wonderful case of metastatic neuroendocrine tumor to the patient's liver. Okay, what a great case. This patient presents with jaundice. There's a large mass in the liver and there's central duct dilatation. So what are you thinking about? You can think about hepatoma, but most hepatomas don't cause dilated ducts. You can think about metastasis. You can think about a tumor infiltrating from like the pancreas growing up, but the pancreatic duct is not dilated. The most likely thing I'm going to say here is cholangiocarcinoma. Cholangiocarcinomas are central tumors in the liver, often solid, not very vascular, and cause duct obstruction. So that's my most likely diagnosis. But if you got to think beyond there, I do want to make the point that one disease that we don't think about very commonly in the liver is going to be lymphoma. Lymphoma can involve the liver when there are multiple nodes elsewhere and multiple organ involvement, but I don't see anything else here. But you can get primary hepatic lymphoma. It can be a solid mass which is infiltrating. You can see in this case, look how it infiltrates around the portal vein. The portal vein is encased, but it's not occluded. So what about lymphoma? There it is again. What is it? Lymphoma. Lymphoma infiltrating the hilum of the liver. Again, I still will tell you when I see this case tomorrow morning, or a similar case, I would have said cholangiocarcinoma, particularly in light of the duct dilatation. When I see lymphoma of the liver, it's multiple masses usually, or even a solid mass, but I don't typically see duct dilatation. That's usually the hallmark of a tumor infiltrating in, like pancreatic cancer, or maybe a gallbladder cancer growing up, but this was a wonderful example of primary hepatic lymphoma. Well, that's the end of my cases. I hope this helped you. Again, you can't always make a very specific diagnosis off 2 images, but it leads you to think about things. You need to have your mind working and thinking, what is it that could be? What am I considering? What am I excluding? What am I counting in? And we'll see you again with next month's You Make the Call. Have a great day, everybody. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.